Devices are used when medications alone cannot adequately correct conduction abnormalities or prevent sudden cardiac death. These interventions improve rhythm stability, symptoms, and survival. The major cardiac devices including pacemakers, ICDs, CRT devices, and catheter ablation. These therapies exist because some arrhythmias require electrical correction rather than pharmacologic suppression. Selecting the appropriate device depends on the specific conduction abnormality and patient risk profile. Pacemakers provide electrical stimulation when intrinsic cardiac rates are too slow. They are necessary because diseased conduction systems cannot reliably maintain adequate heart rates. Pacemakers improve symptoms and prevent syncope in patients with significant bradyarrhythmias. ICDs continuously monitor cardiac rhythm and deliver shocks or pacing therapies for life-threatening ventricular arrhythmias. They are indicated because patients with prior VT, VF, or severe structural heart disease remain at high risk for sudden cardiac death. ICDs significantly improve survival in high-risk patients. CRT synchronizes ventricular contraction in patients with heart failure and conduction delay, especially left bundle branch block. Simultaneous pacing improves ventricular coordination and cardiac output. CRT reduces symptoms, improves functional status, and lowers mortality in selected heart failure patients. Catheter ablation destroys abnormal conduction pathways or ectopic foci using radiofrequency energy or cryotherapy. This strategy exists because some arrhythmias arise from localized electrical circuits that can be permanently eliminated. Ablation may provide curative therapy for AV-NRT, AVRT, atrial flutter, and selected atrial fibrillation or ventricular tachycardia cases. When to use each device and what it does. Pacemakers treat slow rhythms, ICDs prevent sudden cardiac death, CRT improves synchrony in heart failure, and ablation removes arrhythmia sources. Clinically, matching the intervention to the underlying electrical problem is essential for optimal outcomes. This comparison highlights the difference between pacemakers and ICDs. Pacemakers prevent symptomatic bradycardia, while ICDs detect and terminate ventricular tachyarrhythmias. Understanding their distinct roles is essential because they address fundamentally different electrical problems. The ACLS approach to arrhythmias. The first question is whether the patient has a pulse. This distinction matters because pulseless rhythms require immediate cardiac arrest management, while perfusing rhythms require rhythm-specific therapy. Rapid assessment determines survival. Pulseless ventricular tachycardia and ventricular fibrillation require immediate defibrillation and CPR. These rhythms produce no effective cardiac output because ventricular contraction becomes chaotic or excessively rapid. Rapid defibrillation is the most important determinant of survival. Outlines the management of tachycardia with a pulse. The clinician first determines whether the patient is unstable. Instability develops because rapid rhythms can critically impair cardiac output and organ perfusion. Unstable tachycardias require immediate synchronized cardioversion. Stable narrow complex tachycardias usually arise from supraventricular reentry circuits. AV nodal blockade using vagal maneuvers, adenosine, beta blockers, or calcium channel blockers interrupts conduction through these circuits. Mechanism-directed therapy allows rapid and safe rhythm control. Stable wide complex tachycardia should be assumed to represent ventricular tachycardia until proven otherwise. Antiarrhythmics such as amiodarone or procainamide suppress abnormal ventricular conduction pathways. Cautious management is essential because inappropriate AV nodal blockade may worsen the rhythm. Wide irregular tachycardia is particularly dangerous because it may represent polymorphic VT or atrial fibrillation with pre-excitation. These rhythms can rapidly deteriorate into ventricular fibrillation. AV nodal blockers must be avoided because they may accelerate conduction through accessory pathways. Symptomatic bradycardia management. Atropine increases heart rate by reducing vagal influence on the SA and AV nodes. If ineffective, pacing or vasoactive infusions are used to support cardiac output. Prompt treatment restores perfusion and prevents cardiac arrest. This final summary reinforces the core ACLS framework. Pulseless rhythms require defibrillation, unstable rhythms require cardioversion, stable rhythms require ECG analysis and targeted pharmacotherapy, and symptomatic bradycardia requires atropine or pacing. Clinically, this simplified algorithm supports rapid and accurate emergency decision-making.